Today we'll be talking about the drug Warfarin. Now, Warfarin is one of the excellent, very commonly used drug for so many indications. We must know that the duration of action of this medicine is around 3 to 6 days. Now, what is Warfarin? Warfarin actually inhibits the vitamin K dependent clotting factors in the liver. We must know that vitamin K is very essential in the liver to synthesize the clotting factors, which are 7, 9, 10, and 2. So, uh, as it inhibits this vitamin K dependent synthesis of the clotting factors, automatically the regeneration of the active forms of vitamin K is inhibited. So, actually, it inhibits the factor 7, 9, 10, and the protein C and protein S as well. The anticoagulant effect of this medicine actually develops over a period of 1 to 3 days because already whichever clotting factors are formed, they are in the active form and they decline progressively over a period of 1 to 3 days. That is the reason why whenever we ask for INR testing, we usually ask to do the INR testing around 3 to 5 days later the onset of warfarin. We must know the half-life of factor 7 is around 6 hours, factor 9 is around 24 hours, factor 10 is around 40 hours, and prothrombin factor, the half-life is around 60 hours. Uh, the larger initial dose hasten the effect only slightly. That is the reason why it doesn't matter whether you start 4 milligram of warfarin or 7 milligram or 8 milligram. Even if whatever larger dose we use, it is not going to affect the INR very rapidly. So usually around 4 milligram or 5 milligram of warfarin is started, and it is usually the initial dose whenever the warfarin is started. It gets absorbed very rapidly and completely from the intestine. So absorbability of this medicine is very good. It is 99% plasma bound. It is secreted in milk, but it has a very insufficient effect, so can be given in pregnancy as well. The adverse event or adverse effect of this drug is bleeding, we know. So, especially whenever the INR is more than 4, then the chances of bleeding is it is exceedingly high. So INR has to be monitored very regularly, and the target, whatever it is usually from 2 to 2.5 or 2.5 to 3. That target has to be always achieved or always monitored. Whenever there is bleeding from the warfarin, then usually around 2 to 4 FFP are given, which gives a fresh source of clotting factors and which actually inhibits the bleeding. And then vitamin K is usually started. The usual dose to start is around 30 milligram IV, and which is followed by 10 milligram IV per day for around 5 days till that INR is achieved. Uh, Vitamin K dependent synthesis of clotting factors, it takes around 6 to 24 hours for resynthesis. That is the reason why giving FFP is very, very essential. That is the reason why vitamin K action will take around 6 to 24 hours to come into the picture. We must know that warfarin actually is bound for so much of enhancing or reducing effects. Debility, malnourishment, malabsorption. It gives a very poor supply of vitamin K. That is the reason why warfarin effect is so much enhanced. So warf can increase the risk of bleeding in debilitated patients, malnourished patients, or those patients who have malabsorption. In liver disorders, in chronic alcoholics, this clotting factor synthesis is deficient because of the deficiency of vitamin K and because of the poor functioning of the liver. In a hyperthyroid state, the clotting factors are very degraded faster. That is the reason why that can be a problem, or the clotting factor deficiency can be there, which can increase the risk of bleeding. The antibiotics, usually the broad spectrum antibiotics, they very commonly inhibit the gut flora, and that is how they reduce the vitamin K production because vitamin K is produced in the gut by the gut flora as well. The drugs like aspirin, phenytoin, they displace warfarin from the protein binding site and they increase the warfarin action. That is the reason why with aspirin, with phenytoin, the risk of bleeding can be significantly higher, or the INR can be achieved even with lower dosage. Or we have to be much more cautious whenever we are giving warfarin with aspirin or phenytoin, or we have to switch to some other drugs which can reduce this effect. So many drugs like amiodarone, metronidazole, levofloxacin, ofloxacin, paracetamol, tramadol, phenytoin, which are very, very commonly used, they reduce the metabolism of warfarin, and that is how they can increase the INR very rapidly, and that is how the patient can have significant bleeding. So whenever a patient is on warfarin, then we have to be very cautious whenever we are using polypharmacy like levofloxacin, paracetamol, tramadol, phenytoin, and all the drugs. So whenever patient is on warfarin, we have to be very cautious about what drugs we are using. Now, about targets, INR targets, most of the time for DVT prophylaxis, the INR target is 2 to 2.5. For the DVT treatment, that is deep venous thrombosis treatment or pulmonary embolism treatment, for hip surgery, for post hip surgery, for DVT prophylaxis, for TIA, for recurrent TIA, the INR target is from 2 to 3. And if the patient, even on warfarin, if they are getting recurrent thromboembolism, or if the patient has prosthetic heart valve, they have significantly higher risk of embolism. In those patients, the INR target is kept from 3 to 3.5. Uh, there is one very interesting thing, that warfarin is not directly started because warfarin has prothrombotic activity. Hence, it is always bridged with Clexane or heparin, that is unfractionated heparin or low molecular weight heparin, whenever we need to start warfarin for the first time. So Clexane or low molecular weight heparin or heparin is given with warfarin at least for 5 days, and then this heparin is discontinued and warfarin is continued. And thereafter, warfarin has to be monitored very regularly, preferably around 7 days, uh, every 7 days for a month or two, and then every month once the INR is very, very stable. Regarding usage, after heart attack, after MI, whenever the patient has very high arterial thrombus load, then only warfarin is given very commonly in a very low dose, like from 1 milligram to 2 milligram. If the patient doesn't have that much of high arterial thrombus load, then usually warfarin is not necessary. Post CABG, it is very commonly used, and it is always used in a very, very low dose, usually 1 to 2 milligram, most of the time in post CABG patients. In mitral stenosis patient, as we know, that because of the increased left atrial pressure, because of the increased left atrial diameter or size, chances of blood stasis and chances of forming clot is very, very high. That is the reason why there, for prevention of clotting, warfarin is very commonly used. As we know, the risk of clotting, the risk of embolism is extremely high in prosthetic valve. So, post prosthetic valve placement, warfarin is very commonly used, and it is preferred to the novel oral anticoagulants because warfarin has been there in the market since so many years, and these newer drugs, they are in the market since recent years. So, most of the heart transplant surgeons who are there, they can definitely prefer warf, though so many patients are put on novel oral anticoagulant drugs as well. For CVST, warfarin versus again novel oral anticoagulant drugs like apixaban or rivaroxaban or dabigatran can be considered. But warfarin is very commonly used to prevent the to treat as well as to prevent the recurrent venous sinus, cortical venous sinus thrombosis. For deep venous thrombosis as well, warfarin again in the dosage of 4 to 5 milligram or 6 milligram or 7 milligram till the target of 2 to 2.5 INR is achieved. For pulmonary embolism treatment, for prevention of the pulmonary embolism, warfarin is again used, and the target of INR 2 to 2.5 or 2.5 to 3, depending on patient's individual characteristic, is used. For arterial thrombosis like radial artery thrombosis, ulnar artery thrombosis, or posterolateral artery or popliteal artery thrombosis, those patients who are initially treated with heparin or low molecular weight heparin, and those patients when they are discharged, then again warfarin can be considered against novel oral anticoagulant drugs. And again, the target will be INR of around 2 to 2.5 or 2.5 to 3, depending on the individual characteristic of the patient. We must know that the antagonist for this warfarin is vitamin K. That is the reason why anyone, whenever pre-surgery, if we want to achieve the INR of around 1 to 1.5, then very commonly either FFP is given or vitamin K is given to achieve a INR target of 1 to 1.5 before any elective surgery. The problem with warfarin is marked variability. We must know that we have to recheck INR after 3 days, 5 days, and then according to that only we have to increase the dose. Now, the INR, if it is 1, now we are not sure ki it will come to 1.5 or 2 or 2.5. We simply have to repeat it. We have to, if the INR is not achieved, then we have to increase the dose by 1 milligram. This is how usually the warfarin dosage is increased. So it shows very variability when our target is INR achievement. Apart from that, it has very much drug to drug interaction. As we told, there are so many antibiotics, paracetamol, tramadol, levofloxacin, ofloxacin, phenytoin, aspirin. So many drugs interfere with the warfarin, and they may markedly increase the risk of bleeding, or they may reduce the warfarin effect. So this drug to drug interaction is a problem, which is not a problem with novel oral anticoagulant drugs. So this was all about warfarin. One thing that I mistakenly spoke, that warfarin is secreted in milk, but in very much insufficient effect. So actually, it is not used in pregnancy. Warfarin is contraindicated in pregnancy, so it should not be used, not to be used in pregnancy. So that is all about today's talk. Thank you so much.